Hello everyone, in this video we will be discussing the radial artery forearm flap mainly related to the planning and designing. We already have a video on the planning of the distally based radial artery forearm flap, but in this video we will discuss number of other factors which are to be considered while designing a radial artery forearm flap. We will be discussing the skin paddle designing. We will discuss when to take a proximal paddle, when to take a distal paddle, the pros and cons of the proximal and distal skin paddles, and in case of bone harvest, how do we decide the area and why. So we will begin with the axis and markings. The first point is around 1 centimeter below the midpoint of the antecubital fossa. Then we mark the tubercle of the scaphoid or the area distally where the radial artery is palpable. And the line joining these 2 points is the axis of the lateral intermuscular septum. So in this lateral intermuscular septum lies the radial artery and its vena comitatus. So conventionally our flap should be centered on this axis. Now laterally we have the brachioradialis from this axis. Medially we have the FCR, the pronator teres. So the radial artery proximally lies between the bellies of the brachioradialis and FCR, brachioradialis and the pronator teres. And as it goes below, it comes to lie between the tendinous parts of the brachioradialis and the flexor carpi radialis. Coming to designing of skin flaps, if we see larger flaps, almost the entire forearm can be harvested on the radial artery, except for a 3 centimeter area on the subcutaneous border of ulna. All the other forearm skin can be safely harvested. That area is also kept mainly because we need that for the venous drainage. We also don't want to have post-op lymphedema, so that 3 centimeter width over the ulnar subcutaneous border is to be kept intact. Now of importance here is designing of smaller flaps. Now if we see the anatomy of the perforators going from proximal to distal, the proximal perforators are larger in size, they are more apart from each other, they are distantly placed from each other, and as we go distally, the perforators are numerous in number but smaller in size. So the problem here lies if we want to design a smaller flap on the proximal aspect of forearm. So what happens is, if we design a smaller flap and we don't incorporate the perforators, our flap is likely to fail. So when we design a smaller flap in the proximal forearm, it is necessary that we